Hello, everyone. I'm Dr. Setareh Samimi. I'm a hemato-oncologist working at Sacré-Cœur Hospital in Montreal, Quebec, in Canada. Today, I'm going to go through an overview of the esophagus cancer with you guys. So esophagus cancer is the eighth most leading cancer worldwide. Its prevalence varies depending on the regions on our planet. There are two main type of esophagus cancer. One is called squamous cancer, which is usually more in the upper area and the middle area of the esophagus. So we call it cervical and middle esophagus. And the other one is the one we call adenocarcinoma, which is mainly in the distal or the inferior part of the esophagus. Like most cancer, these cancer can also have tumor detach and spread to other organs, which we will call metastasis once we do the investigation. There is no main cause that explain why this cancer happens. However, there are multiple risk factors that have been that are known and have been implicated. They could vary depending on a geographical and on the subtype of esophagus cancer. However, the main are obesity, reflux, which is basically the content of the stomach that comes back in the esophagus and with time cause inflammation and becomes a precursor of dysplasia and cancer growth. Cigarette smoking, as well as consumption of alcohol, are known risk factors. Age above 60, as well as the masculine sex, are risk factors known. Depending on the geography, there are some hot liquid drinkage that are associated with esophagus cancer, as well as some chewing of some plants in some regions of the world that are associated. What could be the signs and symptoms indicative of this cancer? So typically patient can have some discomfort or difficulty swallowing, whether it's the saliva, food, starting from more solid and then liquid food. The discomfort can be felt in more in the throat area or more lower in the mediastin between the chest. This can be associated as well with pain. Pain can be on the same location or felt in the back, like a point in the back. People can feel that their voice change, a more rauque voice. Sometimes coughing can be associated. Spitting or throwing up blood can be seen. Sensation of reflux that gets worse and worse can be also one symptoms. Loss of appetite, weight loss is something that is usually seen as well. How to make the diagnosis of esophageal cancer? So an endoscopy, which is called gastroscopy or EGD, is a camera that goes through the mouth and goes to the esophagus where the tumor will be seen and a biopsy will be taken. Another endoscopy used is what we call echoendoscopy, AUS, which has an echography probe attached endoscopy, which allow to have a better imaging of the depth of the tumor in the esophagus and also of this lymph node area around it. Permit as well to do biopsies if needed, and also to have a better look at the liver and the peritoneum to see sometimes if there's already evidence of spread disease. After in radiology, we use the CT scan of the thorax, the chest, and abdominopelvian, which allows us to see the extent of the tumor, the lymph node area around it, and if there's a spread of the disease to the other organs, for example, the lungs, distant lymph nodes, bones, or liver. The PET scan, which is a tomodensitometry with the emission of positron, it's another imaging that mainly permit us to see if there is distant metastasis but that were not catched up on the CT scan. The blood test can also be helpful more to indicate us sometimes some signs or show us the comorbidity of the patient that might dictate us or guide us in our treatment options. For the treatment, it will depend on the stage of the disease. So if a disease is localized and we believe that there's a hope for curative intent, most of the time surgery will be part of the treatment plan. And then before the surgery, mostly there will be a treatment indicated that we call neoadjuvant. So those treatment could be either with chemotherapy alone or with chemoradiation, depending on the choice of the medical team who will look at the imaging and the other characteristic of the tumor in the patient to make the best decision. There is as well sometimes study protocol that could also be indicated. Once the surgery is done, depending on the protocol that was used, there could be more chemotherapy afterwards or sometimes immunotherapy, depending on the results of the pathology specimen after the surgery. In some cases, the disease is not operable or the patient has comorbidities that don't allow a surgical act. However, the disease is still contained and sometimes we can still aim for a curative intent with chemoradiation that we call radical chemoradiation. And lastly, for patients that have a more advanced disease or disease with metastasis for a stage 4 disease, the intent is to try to control the cancer, prevent it from progressing, allowing us more time for the patient, and also hoping to have better control of their symptoms to alleviate them from the symptoms they might have. So in those cases, most of the time, it will be a chemotherapy with added immunotherapy or other target therapy, depending on the pathology and the molecular testing that will be done on the biopsies of the tumor. And in some cases, more advanced cases, we can also sometimes use radiation for palliative, either on the primary tumor or on metastasis that cause pain, and sometimes use what we call a stent to open up the esophagus to allow patients to better eat. For patients that have a curative intent after the treatment, there is also a very big period for them to adjust to all the anxiety and the depression that might come once the big period has passed. So it's very important to have those discussions, whether it's with your nurse or with your doctor, and to be also referred to the right clinicians with the psychology help that is needed. Patient can also have trouble with their with their nutrition afterwards, especially after some of the surgeries. Again, it needs to be addressed with the team and make sure that the nutritionist is part of the team to help in that context. And sometimes it's needed if there is some narrowing or stenosis. Sometimes we do go back and try to dilate if that is a complication following the treatments. With the chemotherapy, sometimes patients will describe some loss of memory or trouble with their concentration. This is usually a temporary side effect that with time will go away. Finally, for the follow-up, it will depend on your team and on different guidelines, but mostly a follow-up, it will be done for the years to come to make sure that you don't have any symptoms that would trigger your doctor to want to investigate or do imaging and make sure that the disease is not back. So these are a few minutes of summary or overview of the esophagus cancer. I hope it helped answer some of the questions you have and to give you the opportunity to ask more precise questions to your doctor if needed. Thank you.